A very warm welcome to all of you. I'm Dr. Neelesh Singh, Senior Lecturer, Department of Periodontology, BBDCODS, BBD University. Today we are going to discuss a very important topic on scaling and root planing, which is the most basic treatment modality in the periodontology. So here we start. The contents we will be dealing with the periodontal non-surgical instruments and the principles of instrumentation. We are not going to deal the surgical instruments here in this lecture. Periodontal non-surgical instruments. Periodontal instruments are designed for a variety of purposes, basically the calculus removal, root planing, gingival curettage, etc., etc. Now, any instrument or any periodontal non-surgical instrument or any instrument basically has three parts, A, B, and C. The A is handle, B is the shank, and the C is the working end. Basically, the shank is that part of instrument which connects the handle to the working end. Coming on to the classification of the periodontal instruments. Periodontal instruments are divided into three types: the diagnostic instruments, scaling instruments, polishing instruments. Diagnostic instruments are mirror, probe, and the explorer. Scaling instruments are manual and powered. Polishing are polishing bristles, polishing cups, and air polishing systems. Now, the dental mirror basically has a function of indirect illumination, indirect vision, mobility checking of the tooth. Dental probes are basically used to locate, measure, and mark the periodontal pockets. Dental explorer is used to locate the calculus, caries, restoration overhangs. Then the manual instruments of the scaling. They are basically used for supragingival scaling and the subgingival scaling. For supragingival scaling, the instruments are sickle scalers, posterior Jacquard scalers, cumene scalers, and the surface scalers. For subgingival scaling, they are hoe, uh, chisel, files, and the curettes. A very special point about the curette is that it is used to plane the root surfaces by removing altered cementum, scraping the soft tissue wall of the periodontal pocket, which is known as the curettage. This is the picture of the curette in the usage. Now coming on to the powered instrument, they are basically the piezoelectric scalers which we very commonly use in our dental practice. Then the polishing bristles, cups, and the air polishing systems. These are the photographs of these important instruments of the periodontology. Now coming on to the periodontal probe, it is the most widely used diagnostic tool for the clinical assessment of the amount of destruction in the periodontitis. Now, the two important characteristics of periodontitis are the increased probing depth and the loss of clinical attachment. Now, pocket probing is crucial and mandatory for the diagnosis of periodontitis and evaluating its treatment outcomes. Periodontal probes are divided into five types, that is, according to generations: first, second, third, fourth, fifth generation. The first generation is conventional or manual probes. Second generation is the constant pressure probes. Third generation is automated probing systems. Fourth is 3D probing systems. And fifth is ultrasonographic probes. Now, in today's lecture, we'll deal with only the manual probes, that is the first generation probes. A manual probe is basically a blunt rod-shaped instrument that may be circular or rectangular in cross-section and is calibrated with millimeter markings. That is, our instrument, which is under the discussion, is periodontal probe. It is a scale for the oral cavity. The working end and the shank meet at a defined angle, which is usually greater than the 90 degrees. That is, it is obtuse angle. Now, what are the functions of the periodontal probe? The primary function is to detect the probing pocket depth and also to measure the clinical attachment loss, extent of recession, width of attached gingiva, size of intraoral lesions, to assess bleeding on probing, etc. and etc. There are lots and lots of functions of the periodontal probe. Now, these are the types of the manual probes, basic types of manual probes. The first one, A, is the Marquis color-coded probe. It has calibrations at 3 mm. The B is very commonly used UNC 15 probe. Now, what is the full form of UNC? It is University of North Carolina. This is the full form of UNC. Now it is a 15 millimeter long probe with marking at every millimeter, and bands are present at 5th, 10th and the 15th millimeter marking. Now coming on to the C, that is the University of Michigan O probe with Williams marking. In this, total 10 millimeters markings are present, out of which the fourth and the sixth marking is missing. Now why it is missing? It is basically to make the location of the fifth marking easier for the operator. Now coming on to the D, it is the Michigan O probe that is having the markings at 3, 6 and 8 millimeters. Now the E is WHO probe. Now a special thing about this probe is that it has a ball at the tip of the instrument, that is zero point 0.5 millimeters diameter ball is present. Now why it is present? It is to prevent any trauma to the soft tissues while doing the probing. Now it has the markings at 3.5, 5.5, 8.5 and 11.5 millimeter with a band from 3.5 to 5.5 millimeter markings. Now the plastic probe. Now previously what I have told, they are made up of metal. Now, this probe is plastic probe. Now why the plastic is used? It is basically used to probe against the implant surfaces, so that when the metal probe is used, it will be, there are chances of getting scratched. The instrument can scratch the implant surface. So to prevent this, the plastic probe is used. Now, this is an example of a computer-assisted probe. It is known as Florida probe. Just a photograph so that you can see that what are the computer-aided probes look like. But we are not going to discuss in this chapter. Now, coming on to another type of manual probe, this is a neighbor's probe. It's a curved probe, basically used to assess the furcation area. Now, what is a furcation area? It's an area where the multi-rooted teeth, it's an area in the multi-rooted teeth where the roots divide. That area is known as furcation. So to assess that area, the neighbor's probe is used. Now it has markings at 3, 6 and 9 millimeters and there are bands. Now a question arises, how to probe? Probe, how will we do a probing around a tooth? Now to do a probing, there are 6 sites, 1, 2, 3, 4, 5, 6. What are these 6 sites? It is mesiobuccal, midbuccal, distobuccal, then this is mesiolingual, midlingual, and distolingual. There are 6 sites of the probing we have to do. Now, there is a very important thing that in each surface, for example, if we take the surface 2, that is mid-buccal surface, for example, there are 3 readings coming while doing a probing, like A, B, and C. C is the most deepest reading which is coming. So what we will assign to the surface 2, the most deepest reading we will assign to that surface. Now, what is the correct adaptation of the probe? Probe should slide onto the surface of the tooth. It should not be parallel to the long axis of the tooth. It should slide onto the surface of the tooth so that it can move according to the surface. Now, if you want to assess the area of the pocket which is just beneath the contact surface, contact point, this green surface is the green shaded area is the contact point which is depicted. Now, if you want to assess just beneath this contact point, you cannot go very perpendicular or very parallel to the root surface, or sorry, longitudinal axis. What you have to do is slightly tilt the probe so that you can reach beneath the contact point, so that this deep portion can be probed. So we have to probe from the lingual side, we have to probe from the buccal side. This is the way we have to probe in the contact areas, beneath the contact areas, that is interproximally. Now, what is the motion or what is the stroke of probing? It is known as the walking of the probe or walking stroke. Now, how we have to do is, first we have to follow my cursor. First we have to insert the probe inside. Then we have to lift a bit, move in the front, again insert. Lift it, move in the front, again insert. Lift it, move in the front, again insert. So you have to do like this. So this is known as the walking of the probe. Now coming on to the second type of instrument, that is explorer. Now they are used to locate the subgingival deposits in various anatomies or areas and to check the smoothness of the root surfaces after root planing. Explorers are designed with different shapes and angles for the variety of usage. The most common combination of explorers which we use is A and B. This must be seen by every individual. One side is like this and the other side is like this. Now, what are the numbers of these two? This you have to remember. A number is 17 and B number is 23. So the instrument number is 17 by 23. Now coming on to the scaling and the curettage instruments. Now scaling and the curettage instruments are basically of 5 types. It is curette, the front blunt portion, it is curette. If the similar instrument and it is pointed at the tip, it is scaler. C, this is a file. D, this is a chisel. And E, this is a hoe scaler. Now coming on to the sickle scalers. Now sickle scalers basically are used to do the scaling of the supragingival portion of the tooth. Now what are the functions of the scaler? I have told it. Now working design. Now see here, we'll understand the working design from the picture. The working end of the scaler. Now first of all you have to remember is that the tip is pointed. The cross section of the working end, that is, if you cut the instrument from here, this green portion is the cross section, and you can see here is the cross section. Inverted triangle is the cross section shape of the scaler. Now these two are the points, one this red point and the another point is this red. These two are the cutting edges. Another very important point to be noted is that the face of the working end, that is this yellow portion, this portion is the face of the instrument. Now this portion is perpendicular to the shank or the lower shank. See, this is the face of this red line is the face of the instrument which is perpendicular to the lower shank. This is how a scaler can be identified. Now application is anterior teeth, only one single-ended instrument is needed. Posterior teeth, one double-ended instrument is the needed. Now primary function, I have told it earlier. Now this is the basic design characteristic of the sickle scaler. Now coming on to the universal curettes. Now curettes are of many types. The most important are the universal curettes and the area specific curettes, which we will move on to the later ones. Now, the universal curettes. The universal curettes basically this you can understand first from here. The tip is rounded or the blunt. Now, if you cut it to see the cross section, this again that green portion, we get two cutting edges. This is the cutting edge 1 and this is the cutting edge 2. Now, the base of the curette is also rounded. In this, the scaler, the base is also pointed. As I have told it earlier that it is inverted triangle. So the base will be pointed. Here, the base will be rounded so that the deeper portion of the pocket or the soft tissues should not be damaged, as the curette is used to do the scaling below the gingival margin, that is subgingival scaling we have to do with the curette. And again, the face of the instrument is perpendicular to the lower shank. This is the face. This is the face of the instrument, which is perpendicular to the lower shank. So this is the design characteristics of the universal curette. Now, what are the numbers of the universal curette? 4R4L, Columbia 4R4L, and 2R2L are most common universal curettes which are used. Now, these are the area specific cure. Now, as the name suggests that these instruments are specified for different areas. So it's a set of instruments. Some instruments are used for some areas and other instruments are used for the other areas. So this is a very important and a very good set of the instruments used for the periodontal scaling and the root planing tasks. Now, again, the same photograph. If you cut from the face of the instrument, the cross section, again, this green portion, we see this slant on the face of the instrument. There is a lower cutting edge and there is a higher cutting edge. Okay. Now, what happens is the lower one is the actual cutting edge, not this higher one. And again, the same according to the curate, the base is rounded so that when we go deep inside the pocket, the soft tissues will not be damaged. Now, a very important thing that previously in the universal curates, the 90-degree angle between the face and the lower shank. In the scalar also, we have 90-degree between the face and the lower shank. But in the area specific curate, we have an offset angle, that is, it is 60 to 70 degrees as it is slanted to one side. So what helps it this to make it makes a offset angle from the lower shank, that is of 60 to 70 degrees. This is very important to be noted that it has an offset angle. Now, how to engage an instrument with the tooth surface? Sickle scaler, the face is 90-degree. Universal curate, face is 90-degree to the lower shank, and the area specific curate, it has 60 to 70 degrees. So these two instruments, the sickle scaler and the universal scaler, they need to be tilted a bit towards the tooth surface so that these cutting edges can be engaged with the tooth surface. So it's quite difficult. And in the area specific curate, the face is already at a angle. So when you apply the curate to the tooth surface, this is the tooth surface, and this is a 70-degree application of the yeah, area specific curate, it will automatically adapt or engage to the tooth surface, and it is easier to use a area specific curate to scale a surface. Now, these are the area specific curate. This is the most common series, that is Gracie curates. It was given by Dr. Clayton Gracie. These are the instrument sets, Gracie from 1 till 18. Now, what is the distribution? Gracie 1, 2, 3, and 4, they are basically used for anterior teeth of all surfaces of the anterior teeth. Now 5 and 6, they are used anterior teeth, all surfaces, premolar all surfaces, molars, facial, lingual, and mesial surfaces, not on the distal ones. Gracie 7, 8, 9, 10, anterior and premolars all surfaces, and the posterior teeth, facial and lingual only. 11 and 12, anterior, mesial and distal, posterior, mesial, and posterior again, facial, lingual, and mesial surfaces. 13, 14, anterior teeth, mesial and distal surfaces, posterior teeth, distal surfaces. 15, 16, posterior teeth, facial, lingual, mesial surfaces. This instrument was not the actual part of the set which was given by the Gracie. So actually the Clayton Gracie gave from 1 to the 14. 15, 16, and 17, 18 were later on added by other investigators or the scientists. So these are the basic differences between the Gracie curate and the universal curate. This is very important question which can be asked in any exam. Area of use, the Gracie curate, specific areas, specific instruments. Universal, completely adapted to each and every surface of the tooth in whole mouth. Cutting edge, it's at an angle, it is 90 degrees. What is the angle? 60 to 70 degrees. In this, it is 90 degrees. Curvature, it's curved in two planes, it is curved in only one plane. Now blade angle, again the same thing. Offset angle, it is a non-offset angle. Now cutting edge, it has a one cutting edge only, and it is two cutting edges. Now there are certain modifications of the area specific curates. They are known as extended shank curates or after five curates. Now what are these? These are basically shank has been increased in length, 3 millimeters. It is longer than the normal Gracie curates. Now what is the use of this? It can go very deeper inside the pockets which are more than 5 millimeters. So it is easy to go inside the pocket. All standard Gracie curate numbers, they are used, and except 9 and 10. So basically all extended shank curates are the same as the Gracie curate except the 9, 10. The main difference is that it is 3 millimeters longer in the shank. These are the examples of after 5 curates or the extended shank curate. So see, in this, the normal Gracie curate can reach till here, and this extended shank, because of longer shank, can reach very deep into the pocket. Now, coming on to the mini bladed curates, they are the modification of after 5 curates. After 5 curates are modification of Gracie, and these are again the modification of after 5 curate. Now, what is the difference? As the name suggests, mini bladed curate. These are having very small blades. Okay, so these are the numbers 1, 2, 7, 8, 11, 12, and 13, 13, 14. Now, the blade, this is the blade. This is very smaller than the actual Gracie curate. See, this is a very longer blade, and here it has a very small mini blade. These are the certain differences. This is the standard versus after 5. What is the difference between standard and the after 5? After 5 has longer shank. Then this is mini 5, very small blade. And then this is micro mini 5. Again, there is a very small, extremely small blade, so that it can go very easily inside the very narrow but deep pockets. Now coming on to another instrument that is known as curvettes, Gracie curvettes. Now what is the difference between the actual Gracie curate and the curvette is, see, this dotted portion is the Gracie curate. Now this is the almost straight or slightly curved um, working area or working end, but in the curvette it is curved. This is the solid portion is the curvette. It is curved working end. Now what is the advantage of this is basically it can engage more amount of calculus easily, so that it can be slightly, with a small motion, it can be used to engage the instrument calculus basically. Now coming on to another modification, Langer and mini Langer curates. Now basically this is a set of 3 curates, and now it is further a hybrid type of instrument. It is a combination of the shank design of Gracie curate 5, 6, 11, 12, and 13, 14, and blade of instrument which is universal curate. You can understand. See, the shank is of Gracie and the blade is of universal curate. Means the shank belongs to Gracie curate and universal is universal blade. That is, it will be 90 degrees to the lower shank. That is, there is no offset angle, so that it can be easily used for most of the areas of the tooth surface or the tooth in the whole oral cavity. Now coming on to the hose scaler. Now basically what is a hose scaler? Hose scaler is a kind of angled chisel. It is used to remove the tenacious rings of calculus. Basically we have to remember a very important point, that it works on a 2-point contact. One point is the contact which is beneath the calculus, which will be beneath the calculus, like here. For example, see, for example, if there is a calculus present like a ring around the neck of the tooth. So what we'll do is we will put the or insert the hose scaler slowly into the pocket and reach with this blade below the calculus and engage it. So here is the first point of contact, and the another point of contact is in this portion of the instrument on the crown portion of the tooth. So this is the use of hose scaler. So it can be used for removing the tenacious rings of calculus. Now the files are basically used for removing the large chunks of calculus. Files we have already seen in the oral surgery. The similar files are used here also, but in a very small dimension. Chisel scaler, we have already seen the chisels. What is the use of chisel? It is to just do a chiseling motion, so that it can scrape off the deposits. Now coming on to the plastic instruments for the implants, as I have told you earlier, There are plastic probes, plastic curets, plastic scalers, so that when there is any deposition or we want to cure it around the titanium implants, we can use this instrument without damaging the surfaces of the titanium metal of the implants. Now, these are the Schwarz piezo drivers. What is a Schwarz piezo driver? It is a magnetized instrument. If you do a scaling and if a tip of instrument breaks and remains in the pocket, these are used to pull the tip of instruments towards themselves. Now, these are the characteristics of the coming on to the table. This is the differences in the design characteristics, or we can say that design analysis of both the sickles and the curates. Now, back pointed, sickle ka back pointed, back rounded, the curates have a rounded back. Pointed tip, sickle scaler, rounded tip, universal and area specific curates, curved cutting edges, area specific curates, face which is perpendicular to the lower shank, the sickle and the universal, and the face tilting in an offset angle, it is of area specific curates. Now coming on to the ultrasonic and the sonic instruments. They are basically used for removing the plaque, scaling, curating, and removing the stain. There are two types, magnetostrictive and the piezoelectric. Now, main difference between these two is the tip of the magnetostrictive scaler, it vibrates like an ellipse like this. And the piezoelectric scaler tip vibrates like in a linear motion like this, in a line. Now, ultrasonic vibrations range from 20,000 to 45,000 cycles per second. Now, what are the principles of the periodontal instrumentation? The basic principles of the periodontal instrumentation are the positioning of patient and operator, visibility, illumination and retraction, condition of instruments, maintaining a clean field, instrument stabilization and instrument activation. These all points has to be remembered. Now, instrument stabilization is further divided into instrument grasp and the rest. Instrument activation is divided into adaptation, angulation, lateral pressure, and the stroke. Now, first, accessibility, that is positioning of the patient and the operator. The first comes the neck position. There is a neutral neck position. This gray portion is the neutral neck position. Now, green, we can tilt the head of our head till the green position, but we cannot go in the red position. It will strain our neck. Now, neutral back position. The back should be perpendicular to the thigh, or it is perpendicular to the floor. We can go till the green zone, but we should avoid to the red zone. Neutral torso, it should be straight. The torso of the body should be straight. Now, neutral shoulder position. Now, what is the neutral shoulder position? The shoulder should be lowered down. It should not be lifted in the position. The neutral upper arm position, the arms should be very close to the longitudinal axis of the body. We can separate our arms till this green zone, but it should not be so separated like it comes in the red zone. Now, the neutral forearm position. The forearm should range from this green zone to this green zone. Okay, that is 62 degrees. Now, if it is a red zone, if it is in the red zone, then our forearm will get strained. The neutral hand position, this is the neutral hand position. That is, the smallest finger should be lower than the index finger. Now, this is a wrong position where the smallest finger is in line with the, or it is parallel, or is in the same level to the index finger. Now, the feet position. The feet position, this is the correct position of the operator. The feet should be flat on the floor. They should not be kept on each other or crossed. They should not be so narrow. They should be widely separated so that a stable base forms. The back should be perpendicular to the floor, thigh should be parallel to the floor, and the leg should be again perpendicular to the floor. Now, the position for the maxillary treatment area, the main things which has to be remembered is that the feet should be even with or slightly higher than the tip of the nose. In maxillary, this is for maxillary, the feet should be slightly higher than the tip of nose or in the same level. This is the body. Now the chair back. This should be parallel to the floor. Head. This is the headrest. The top of patient's head should be even with the upper edge of the headrest. Okay. So this is the position of the patient for the treatment of maxillary teeth. Now, a very important thing to be noted is it is called as the chin up position. Now, the chin up position is that the chin should be on the raised level. Now, coming on to the position for mandibular treatment areas, body, the feet should be even with or slightly higher than the tip of his or her nose. It is similar to that. The chair back should be 15 degrees to the floor of the clinic. The headrest should be even with the upper edge of the thing. Now, this is known as the chin down position. That is, the neck should be down. That is, the chin should be in a down position to treat the mandibular areas. Now, the next principle is visibility, illumination, and the retraction. Visibility is of two types, direct and indirect. Illumination is of two types, direct and indirect. See, this is the direct vision. I can see the I can see the surface directly through our eyes. Direct illumination, that is the light can be directly thrown on this surface. This is indirect vision, means we see the surface in the mirror for the lingual surfaces of the lower molars. Now, this is the indirect illumination, means the light from the chair is coming onto the mirror and mirror is reflecting to our working area. This is indirect illumination. And this is the combination of indirect illumination and the indirect vision. Now, then comes the retraction. Now, we do the retraction with the mirror very commonly. Retraction of the cheek, retraction of the tongue with the mirror, and retraction of the lip can also be done with the help of our fingers. So, retraction provides everything like visibility, accessibility, and the illumination. Now, coming on to the condition and the sharpness of the instrument. Instrument should be clean, sterile, and in good condition. That is, there should not be any rusting, and it should be sharp, very sharp. The sharp instruments, they enhance the tactile sensitivity and allow the clinician to work more precisely and efficiently. Dull instruments, it leads to a difficulty in the removal of calculus, and if something happens, it can slip the instrument. So, sharpen your sword before doing the job. Now, coming on to the maintaining a clean field is very important. Now, see the picture. You can do a scaling or anything in this area. So you have to maintain a very clean working field so that you can do something. It can be done by using a gauge piece. Okay. Instrument stabilization. Now, stability of the instrument and the hand is the primary requisite for the controlled instrumentation. The stability and control are essential for effective instrumentation and avoidance of injury to the patient or clinician. There are two main factors: instrument grasp and the finger rest. Now, there are instrument grasps which are very common. This is the standard pen grasp and this is the modified pen grasp. Now, I will explain both of them. In the standard pen grasp and the modified pen grasp, the index finger bent at the second joint, means this is the finger, first joint, and this is the second joint. So the index finger is bent at the second joint from the nail and rests on the handle. It will rest on the handle in both the types of grasp, standard pen and modified pen grasp. Now, the thumb. The thumb pad is placed at the opposite end of the handle, almost halfway between the index finger and the middle finger in both the type of grasps. Now, the main difference lies in the placement of the middle finger or the ring finger. In the standard pen grasps, the side of the middle finger is placed on the shank. See, the shank, this is the shank, and middle finger's side is attached to the or placed on the shank. And in the modified pen grasps, the pad of the middle finger is placed on the shank, and it is very effective and stable grasp. It forms a tripod. It forms a tripod, so which is known to increase the stability, control, and tactile sensitivity. Now, coming on to the next type of grasp, it is palm and thumb grasp. It is used for sharpening of instrument. It is not recommended for doing any type of instrumentation in the mouth because there is no precision and control. Now, coming on to the finger rest, it serves to stabilize the hand and instrument by providing a firm fulcrum as movements are made to activate the instrument. A good finger rest prevents the injury, laceration of the gingiva, and surrounding tissues by poorly controlled instruments. Now, ring finger is basically used for doing a finger rest. See, these are the type of rests. Conventional rest means the finger rest is established on the tooth surface immediately adjacent to the working area. Means we are working on the premolar and immediately adjacent to this working area, the this finger is ring finger is used. Okay. Cross arch means if we are working on one side of an arch, the other side of the arch, same arch, is to be used for the finger rest. Opposite arch means if we are doing on the first quadrant, we have to place finger rest on the fourth quadrant. Finger on finger means the finger of the working hand is used to provide a, for example, a table on which our ring finger of the working hand will be placed and be used as a rest. This is finger on finger. So we have four types: conventional, cross arch, opposite arch, and finger on finger. These are intraoral finger rests. There are certain extraoral finger rests also. Now, extraoral finger rests basically are used for the some aspects of maxillary posterior teeth. Like this is the palm up. Palm up means the back of the working hand is placed on the symphysis or the parasymphysis areas basically of the mandible. And this is the palm down. It means it is the pads of the fingers are placed on the parasymphysis region of the mandible. Now, basically, they are divided for different areas. This is for the lateral aspect or buccal surfaces of the mandible on the right side of the face, and this is on the left side of the face. Now, both the intraoral finger rest and extraoral fulcrums can be reinforced by applying the index finger of the non-working hand on the shanks of the instrument so that the precision and the pressure increases, and this increases our capability of scaling. Now, coming on to the instrument activation, there are four steps of the activation. First, we have to adapt the instrument. Then we have to angulate the instrument so that it can engage the calculus. Then we have to apply the pressure, which is known as lateral pressure, and we have to give a stroke. So this is the type of steps of the instrument activation. Now, first of all, the adaptation. Now, adaptation of the instrument is done at A portion of the working end. It should not be C or B. Now, what happens? This happens. See, this is a blade, similar thing. If the A portion is adapted, it is well adapted to the tooth surface. Now, if it is the B portion, see the middle portion is adapted to the tooth surface, the A portion becomes free or becomes more widened out so that it can damage the soft surfaces of the pocket, that is the tissue surfaces. So this is right and this is wrong. Now, angulation. Third step is first is adaptation, then angulation. Now, there are variety of angulations for different purposes. This is also known as a tooth blade relationship. Now, blade angle. Now, if there is no angle between the face of the instrument and the tooth surface, this is for blade insertion. This is how we have to insert the blade in the pocket. Now, if there is 45 to 90 degrees, it is for scaling and root planing. Then, if it is less than 45, it is incorrect. and if it is more than 90, it is for curettage. Okay, in this way we have to insert in the pocket. If it is less than 90, that is 45 to 90 degrees for scaling and root planing, very less, incorrect. And if it is obtuse, means this edge will not be used because it becomes almost parallel to the tooth surface. This line, straight line, vertical line is the tooth surface. Now this working end or cutting edge becomes activated, and on this side of the pocket is what? It is soft tissue. That is soft tissue wall of the pocket. So this will scrape the soft tissue wall of the pocket, and that is known as gingival curettage. Now coming on to the lateral pressure. Now pressure created when the force is applied against the surface of the tooth, it is known as lateral pressure. The amount of pressure applied must be varied according to the nature of calculus and according to whether the stroke is intended for initial scaling or for the root planing. So different amount of pressure is needed for different purposes. Sequence is, first we have to apply firm, then we have to slowly reduce, and when we move towards the root planing tasks. Now coming on to the stroke, there are variety of strokes in which different purposes are solved. They are basically assessment stroke, means exploratory, so that we can judge that whether in which area the calculus is present, which areas overhangs of the restorations are present, which is basically given by an explorer or the tip of the scaler. Coming on to the scaling stroke is basically used for removal of the calculus. Root planing is for planing of the root surfaces. Now, vertical and oblique strokes are basically used in most of the tasks for the periodontal treatment. Horizontal strokes are used uh, very less and they're basically used for the line angles in the deep. Now, these are the different types of strokes and their comparison: assessment stroke, calculus, removal, that is scaling, and root planing stroke. Now, assessment stroke is basically used with the help of an explorer. Now, in this, the working angulation, you have to mainly remember about the working angulation of each stroke. Working angulation is 50 to 70 degrees in the assessment. Calculus is 70 to 80 degrees, that is, this is scaling stroke, and root planing is 60 to 70 degrees. Now, what is the character? This is the another very important part. The character of the stroke. Character means it is a fluid stroke of moderate length. It is a fluid stroke of moderate length. Okay. Then calculus removal is powerful stroke, short in length. Now, how these are different is, for removing calculus, we have to give more force, but for short length, that is forceful short stroke. Then for root planing, this is lighter in the force and moderate length. Okay, so these are the characters. Now coming on to the direction of the strokes, this can be vertical, oblique, horizontal. Can be vertical, oblique, horizontal, and this can also be vertical, oblique, and horizontal. So these are very important things: working angulation, character, and the direction. So anyone can ask, assessment stroke is of fluid nature and moderate length. This is short in length and high in force. This is again lighter and moderate length. So this completes our basics of the scaling and root planing and all of the basic instruments which we are going to use in our clinics for scaling and root planing, because scaling and root planing is a very important part of our periodontal therapy. So it has to be remembered and more important, practiced. So I hope you understood. Thank you very much.